The room is yours.
Thank you. So once again, good morning, good afternoon. You've been hearing my voice a bit today. My name is Christopher Lindahl. I'm the Knowledge Management Lead for Momentum Integrated Health Resilience. And we're really excited that you could join us for today's webinar on tailoring interventions based on evidence from a social norms assessment in South Sudan. I hope that you've been able to select your language if you need to, and just a few other housekeeping notes before we really jump into our program. We will be recording the webinar today, and the slides that we're sharing now and the recording in both French and English will be made available on the Momentum website. You can use the chat function throughout today's session to pose questions to the panelists that you'll be hearing from. We'll have plenty of time at the end for a Q&A session. We've got about 90 minutes for our agenda today. So please go ahead and ask your questions as people are presenting, and we'll get to hopefully all of them at the end. And again, for those of you who need, we have interpretation into French, and you can see, again, the little globe at the bottom is how you will do that. Just in terms of our plan for the day, or for the hour and a half that we have together, we'll hear from several colleagues, starting with just a brief overview of South Sudan, focusing on some family planning and reproductive health information. That will be followed by an overview of the methods that were used for the social norms assessments, and really with a focus on the vignettes as one of the main methods for data collection. Next, we'll hear a selection of the findings from the study resulting from the vignettes to illuminate social norms and their impact on reproductive health, family planning, and health-seeking behavior. And lastly, we'll talk about how Momentum Integrated Health Resilience has been using the findings to develop county-level action plans for social and behavior change, and to adjust programming to make sure that our programming addresses and is informed by those existing social norms. With that, I'm going to turn it over to Dr. Dimiti, who is our Momentum Integrated Health Resilience Deputy Chief of Party in South Sudan, to give a brief overview. Dr. Dimiti, over to you.
Okay, thank you. Good morning, good afternoon. I'm going to give a brief presentation on the South Sudan reproductive health context and the situation. First and foremost, the total population of South Sudan is 14,234,977. That is from the National Bureau of Statistics population for 2020 to 2040. Under 5 mortality rate is 100.
Could you restart again? I missed your audio for a bit, so just take over from the beginning. Sorry, Dimitri, go ahead.
Okay, the total population of South Sudan is 14,234,977. That is from the National Bureau of Statistics 2020 to 2040. Under 5 mortality rate is 108. According to the South Sudan Household Survey of 2010. Institutional delivery is 12% from the same source. Skilled birth attendance is a mere 14.7%. Newborn mortality is, I think, one of the highest in the world, 39.3%. Teenage pregnancy between the ages of 15 to 19, the rate is 300 for every 1,000. Girls of the same age. Adolescent birth rate is 158 per 1,000. There is early child marriage contributing to about 45%. And because of protracted and repeated conflicts, reproductive health services are poor, the coverage is poor. In fact, only 44% of the population access health services because the health system is weak. For example, in the issues of human resources, the inadequate number of midwives, especially nurses and midwives. And we are dealing in a context of deeply rooted sociocultural beliefs, which is impacting on family planning access. And that is why Momentum is doing a lot of sensitization and awareness raising in order to be able to encourage access and the accessibility of methods of family planning. Over.
Thanks, Danidi. And before I jump into the methods and all of that, and really getting into all of the aspects of the social norms assessment, just to give a brief overview, kind of high level of the study and its purpose is to generally provide information on social norms related to reproductive health, including menstrual hygiene management, antenatal care, and several other things that you'll hear about later today. Family planning, gender-based violence, and health-seeking behavior. And as I mentioned at the beginning, the study really was conducted to help inform programming, particularly for social and behavior change activities in South Sudan. So Momentum has worked very closely with Breakthrough Action to use these findings to inform various SBC programming. So I'm going to turn it over now to Paul Bukaluki from DevCom, who worked on the social norms assessment, to talk about the methods with a particular focus on the vignettes. Over to you, Paul.
Thank you very much, Chris. Good morning, good afternoon, everyone. I'm Paul Bukaluki from Makerere University. I'm not from DevCom, from Makerere University, School of Social Sciences. I'll be co-presenting with my colleague Moses Okwi from DevCom. And I'll be talking about a unique method that is used to study social norms, and that is vignettes, which basically means use of short stories, which is a projective techniques that enables people to share information about sensitive subjects, including subjects around use of contraception in settings where the norms are still quite conservative around this kind of subject. Next slide. And basically, just to talk briefly about the methods that we used, basically the study design was cross-sectional, a cross-sectional descriptive design, because we applied this at one moment in time. And then we engaged in stakeholder consultations, key informant interviews, in-depth interviews, and within all this, we integrated vignettes. And our vignettes followed what we prefer to call the life course, because we did transcend, for example, from puberty to early adolescent, where issues of early marriage come up, and then to marriage, where issues of negotiating contraception come up, and where there are actually sanctions, including GBV related to health seeking in relation to family planning. We went to a number of states and counties in South Sudan, including Bo, Wau, Yambio, Lel, and Bodi. So just to give you a background around the methodology. Next slide. Basically our sample size included women and men, 15 years, and we called those the younger people, and then it also included 25 to 49 who are sort of adults. So basically our population was of reproductive health age, and it had those that were married and those that were unmarried, because we wanted to see how norms affect different reproductive health behaviors, including menstrual hygiene management, family planning, and health seeking among the married and unmarried younger people and adults. We also interviewed key informants like religious leaders and traditional leaders and elders, as well as primary health care providers. Next slide. So we wanted to know about a number of issues, including knowledge and perceptions that influence family planning, reproductive health, including menstrual hygiene management, GBV, and health-seeking behavior. Particularly, we were interested in understanding the social norms, the normative expectations, and the typical behaviors that influence individuals and couples' intentions around family planning, reproductive health, GBV, and health-seeking behavior, not forgetting also, of course, menstrual hygiene management. And we wanted also to be able to identify reference groups, or if you want, key influencers. And the focus was largely on religious leaders, traditional leaders, and health providers. Next slide. I will focus more on vignettes because we found this to be a unique method. But before I go into details, I just want to explain what we meant by vignettes in the context of this study. These are short guided storytelling methodologies that act as projective techniques. We tell stories, and because we are talking about sensitive subjects, people can easily talk to the story rather than if you ask them direct questions. So here they speak about their experiences, but much more indirectly. And basically vignettes are used both in qualitative studies. So like if you use in-depth interviews the way we did, or if you decide to use focus group discussions, sometimes you also can include them in surveys, and then you ask questions about these short stories. And basically the most important thing about vignettes is that they help minimize response bias. So the social desirability bias reduces, given that actually people are not speaking directly about their experience, but they are projecting this on a story that resonates with their context and the values and practices. Next slide. So the main elements basically of a vignette include a behavior, because in order to study social norms, you must identify a behavior of interest. With this behavior, then you can investigate norms around a particular behavior of interest. But you must also have a clear context, very specific and simple, to which you are applying this story. In this case, we applied this to the context of South Sudan in rural and semi-urban areas. And then the characters, you have to have very clear characters that are relatable to by the target population and the key influencers or opinion leaders like reference groups. Then because you are looking at norms, you also must make sure that the consequences are clear in terms of social, if a norm is challenged, for example, or broken, what are the sanctions? Or if it is adhered to, what are the rewards? And normally we encourage that when we are using vignettes, we use open-ended questions to engage with the story about the norms sustaining a behavior of interest, like a menstrual hygiene management or use of modern contraception, among others. Next slide. So because we were studying social norms, because vignettes are not only used to study social norms, but because we were studying social norms, it was very important to, we found it important to introduce the kind of norms we were looking at. We were looking at descriptive norms. Basically, this means what people perceive to be a typical behavior in their community or reference group. And we also looked at injunctive norms or normative expectations, like what people perceive to be appropriate behavior or approved or accepted behavior in a community or group. We took also interest in the reference groups, like groups that influence individuals' likelihood of complying with the norm through modeling or enforcement. And these are the people actually who enforce sanctions or rewards. Like if you don't comply with the norms, you face certain negative sanctions. If you comply, you may be positively rewarded. Maybe you sit at the high table, maybe you become a leader, among others. Next slide. So in order to make sure that our vignettes are adapted to the context, are relatable to, we went through a process and we started with stakeholder. We started with document review basically to learn more about the context of South Sudan and these behaviors, the norms. But then after that, after developing the draft vignettes, we went through a process of stakeholder consultation to help us review, validate, and adapt these vignettes. Basically, the purpose of this was to make sure that the vignettes are aligned to the context and the population can relate to them. Our population, remember, was that of younger people 15 to 24 and 25 to 49, and healthcare providers. So we wanted to make sure that our target population can relate to these short stories we are calling vignettes. Next, we translated the vignettes in the various local languages. South Sudan is a multi-ethnic country with the more than 40, I think, dialects that are spoken. So we translated in the various local languages. We did pre-test the vignettes and further refined them such that the short stories can resonate with people and people can easily relate to them. Next slide. So, like I said in the beginning, we made sure that our characters, we presented them in such a way that they move from one stage to another. So they start with the stage of puberty, where the concern is around the menstruation and the menstrual hygiene management. Then they move on to being very young adolescents, where issues of negotiations around sexual debut start, and then challenges around early marriage start setting in, because for some of the communities, immediately they see menses is like a rite of passage into saying, oh, you are now a grown up, you can get into marriage, and then transitioning into adulthood to start negotiating decisions around access and utilization of modern contraception. And the sanctions that go with that might actually include stigmatization or divorce or paying back the bride price, among others. So basically, we found this life cycle approach that transcends from puberty to adolescence, adulthood, very useful in terms of creating a platform for discussion and reflection about social and gender norms that related to our behaviors of interest. And it helps the research team to learn about the needs at the different life stages and the norms that regulate meeting those needs, especially in relation to menstruation, reproductive health, family planning, and how health-seeking behavior is regulated through social sanctions. Next slide. Here, I'm not going to go through these vignettes for the interest of time, but I just wanted to show you that we started with Rose's story around the menstruation when she's doing her gender roles and then realizes that she has started menses, and then she starts to think through the norms that regulate how one should behave and the materials that one should use and whom to consult and whose opinion matters, among others. Then Rose and Joe then, as a younger couple who start a relationship, then start thinking about issues of sexual debut, when especially they are not ready for marriage or pregnancy and so on. Then we moved on to issues of early marriage that set in, especially in the South Sudan context, but in many other contexts in Africa and some in South Asia, around the issues of how do you negotiate issues around early and child marriage. Then the next vignette on the next slide went on to look at decisions to use family planning and actually the gender-based violence imposed in terms of sanctions and how people tried to use agency to negotiate around those sanctions and try to access family planning services or modern contraceptive services. And of course, issues around health seeking and innovation is around, for example, here Rose was using the chance that she's taking the son for immunization, and she decides to get contraception and so on. So that life cycle approach helped us to look at that transition from adolescence to adulthood and the negotiations and agency and the barriers to agency actually in negotiating access to the relevant services. Next slide. I just give you an example, and I will not go through all these vignettes, but for us, after we stated the story around her starting menses, we did ask certain questions to help the discussion to go on. Like we were asking, at what point, what does she do in order for us to get the descriptive norms, but also to understand what materials does she use? Because remember, menstrual hygiene management is also related to wash. And then we imagined that if Rose is attending to school, going to school, what is going to happen because of the relationship between starting menses and sometimes drop out of school. And then we also went on to look at the normative expectations or injunctive norms around in her community. Would she be treated differently? People knew she was going through her menses, among others. Next slide, just to give you an example. Next slide. And then, of course, we transition to, for example, the issue of decision to use family planning. And here, we were trying to look at the norms, injunctive norms and descriptive norms that regulate issues around decisions to use family planning, the power relations between couples, and the key influencers, including peers. Like when we ask, what do you think her friends thought about Rose using contraception to delay pregnancy? What about the family? What about the neighbors? Here we were trying now to understand whose opinion matters for her to use contraception. But the beauty about this is not necessarily the vignette or the questions, but the fact that because we were projecting this on a story that people would relate to, they were able to share their experiences around it, norms around couple communication, norms that regulate, we were able to identify the reference groups, the people whose opinion matters, because these would be important to be targeted for SBCC programming. So through the vignettes, people were able to express themselves in a much more natural environment, reacting to a story. Next slide. Of course, we were also able to get through the sanctions, the negative sanctions that accompany using these services, especially without the consent of the husband. But Martha will speak more about the findings, so I'll restrict myself to this. So because we know that sometimes the norms of health providers mirror the social norms that are in the community, we also spoke to providers through these vignettes, and actually we were able to learn that in terms of sanctions, actually we were able to learn that some providers actually would face mob justice if they provided the contraceptives without consent from the husband. And here husband in a collective context does not mean an individual, because an individual is seen to be part of a clan or to be part of the community. And so this even complicates it in terms of negotiations. And we came to realize that there are very strong social sanctions that not only affect the service users, but also the service providers. But it was because of these stories on which people could project their experiences. Next slide. So basically, we learned a number of lessons that I would like to share with you. One, that vignettes must really be co-designed. So co-creation, co-design of vignettes is very important. Them to be validated and translated into local languages and pre-tested to make sure that people can relate to them and they resonate with the context, their needs and experiences. And going through a process of refining and adapting these hypothetical scenarios in vignettes is extremely important to make sure that they are meaningful to the study participants across the life cycle. And also social norms are understood in less abstract ways, especially when you want to understand the typical behavior, but also the normative expectations around the behaviors, to understand the reference groups in terms of whose opinion matters and what kind of sanctions are related to behaviors of interest, like in this case, menstrual hygiene management, or even use of modern contraception. And vignettes provide safe space because people are reacting to a story, not necessarily being put on task to share own experiences. So in terms of do no harm, in terms of ethics, they hope to provide more protection because people will say, well, it was a story and we were simply reacting to a story. And of course, they are very helpful in co-creation of SBC strategies and materials, because these very vignettes can be used to inform, and the findings can be used to inform social behavior change strategies and materials through co-creation processes. Yeah, so in terms of programming implications, just to note that the vignettes help in simplifying and demystifying data collection by using stories and people and the participants projecting their experiences and feelings around social norms that regulate behavior, especially in contexts where it is sensitive. These behaviors and talking about the norms that regulate them are very sensitive, but also they hope to demystify the concepts around the norms, because norms, the subject of norms can be very theoretical and abstract. So we found this to be extremely useful. Thank you so much. Over.
Thank you, Paul, for that overview of the methods and some of the vignettes that were used. I mentioned this in the chat, but just as a reminder for everyone, we will share these slides will be available. So there was a lot of detail, and especially in some of the examples of the vignettes, but you can have an opportunity to look at that in a little more detail as well. I'm going to turn now to Martha Awet, who is the Senior Maladvisor for Momentum Integrated Health Resilience in South Sudan. And she's going to present a selection of the findings from the social norms assessment. We don't have time to go into all of the findings from that, but if you are interested in learning more, I'll put a link to the full report that's available on the Momentum website, where you can really get into a lot more detail. So Martha's going to, again, present a selection of these findings. So I'll turn it over to you, Martha. Go ahead, please.
Thank you. I'm Martha Awet, Monitoring and Learning Advisor in South Sudan. As Chris mentioned, I'm going to present the findings from social norms assessment, which was conducted in 5 counties in South Sudan. And the area of focus will be family planning, reproductive health, BBB, menstrual hygiene management, and health-seeking behavior. Next slide. Okay, these are some norms around the family planning, reproductive health. According to the study population, when a woman is married, she is expected to produce many children, not even one. In some region, the study was conducted depending on its ethnicity. So the family planning requires husband consent. This is the perception, or even in some community, they don't even accept the family planning method, because once man pays the bride price, the woman is expected to produce many children. And in some cases, if a woman fails to produce, then her husband can have a choice of even going to marry a second wife. We can see some quotes from influencers, women and female influencers from different regions, Bor and Lair County. Next slide. Family planning supportive norms were also noticed in some population study areas. When a woman gave birth, then the couple are abstained from sexual activities until the child is able to speak or to walk. This we are talking about the age of 2 to 3 years. In some cases, it happened that they will also lose their dignity in case they interacted with sexual activities in the community. So that one is not allowed in some community in where the study was conducted. And also during the study validation workshop, participants noticed that a woman abstained, though the woman abstained from sexual activities, but the men intend to also involve in sexual partners or all looking for the second wife or getting another woman. This is mainly in polygamous families in South Sudan. Next slide. We observed that there are also some supportive norms, though in some providers initially actually discourage adolescents and youths from accessing family planning method. But during the study, it has been noticed that providers are now encouraging uptake among the school-going adolescents and youth. And also now we can see there are some school-going children are now family planning acceptance. And in some region where the study also was conducted, we realized that some mothers also tend to bring their daughters for family planning services in order to avoid early marriage, which can later lead them to drop out from schools and other reproductive health issues can also come in. And in the rural area, in the urban settings, males are also encouraging their wives to take family planning method. People get now to understand now the importance of child spacing. We can see also some positive quotes from from the male respondents from Wau County, where the study was conducted. Next slide. Some norms around menstrual hygiene management. According to the study population, in different regions, they mentioned that they are using different materials during the menses. For example, some mentioned that they're using pads, some they use leaf, some they use rag, for example, and others they also use to sit in the sand where they can absorb the blood. And in some locations, even they don't use any materials. So other respondents do mention that menstruating girls are usually kept isolated from the people so that it doesn't expose them to any violence or any other beliefs that can lead them to be treated in a isolated or different way in the community. Even in some regions, they said when the girl is menstruating, they are prohibited from certain activities. For example, they should not prepare or serve food to the people or to the elders specifically because they are perceived to be unclean. They are also prohibited from maybe eating a certain food. We can see in the court in the Lair County that this is a taboo for a girl to even milk a cow. So they believe that when a girl is menstruating, milking a cow, they will pay less bright price. Early marriage. The early marriage usually in some cases is caused by either peer pressure, maybe the girls of a certain age, when you see their peers are now married, they are forced, maybe they are also plan to also marry because they think that they are the same age bracket, why not others? And also maybe the early marriage can be caused by unwanted pregnancy. So in some community where the study was conducted, girls are considered to be a source of wealth. Where a girl sees, when a girl sees her first menses or the first period, then they raise a flag. Like the family members organize occasions, and they also announce that their daughters or the daughter is ready now for marriage. So this kind of the norms around. And in that scenario also, father decided when and to who to marry off their daughters. Next slide. These are some emerging supportive norms, and some realize that it is important to marry their daughters off or to marry their daughters when they completed their educational level. And here by educational level, usually they refer to completing secondary school or even university. So they have seen that when now the lady has more, will have more value to when she's now educated, she can be able to provide, to get a better job and provide the basic need for the family. Because at the early, I said there's some supportive norms, because they look at the girl as a source of wealth. But since the girl is educated, they can be able to provide the necessary requirement for the family. So we can see some quote from key influencer from Budi County. Next slide. Some norms around the gender-based violence. It is widely believed in the community, at the community level, that the family planning should not be used at all, and especially among the rural population. At the household level, family planning can easily cause GBV once a man realizes that the woman has, or his wife access family planning without his knowledge, then this one can cause actually a GVB. And in some instance, like this happened in one of the counties, study population in Yambio County, says that when maybe when a lady is menstruating, usually that's why they allow them to be isolated, because when the brother sees that maybe they think that out of ignorance, they think that maybe she lost her virginity. So this one also exposed them to violence. So we also see in some rural population, like local chief, they also impose punishment on the women who are accessing family planning. They punish them up to 6 months of labor in the house of chief, and even they intend also to punish the providers who provide the services to the woman. So these are some issues related to GVB. Next slide. Okay. Health-seeking behavior. The provision of family planning services for unmarried women, they said, is required consent from the spouse. This is the community opinion. But however, according to the national guidelines, South Sudan national guidelines, says that woman has the right to access family planning without the consent from the husband. But here, the community has different opinion about the use of family planning. Even the providers are also sometimes they deny services to unmarried a woman, denied family planning services. And once also the community realizes that a woman is, or unmarried woman is taking family planning or accessing family planning, they also have a misconception that maybe she's identified as a prostitute. Next slide. Looking at the community perspective on the patient providers communication, this information or data has been collected through the obtained through the vignettes used, as had been mentioned by the previous presenter. So the vignettes quote that Rose can initiate a conversation about the use of contraceptive with her husband, with her healthcare workers, sorry. So when we look at the overall, we can see 62% of the respondents says that they agree that yes, Rose can initiate conversation with the healthcare providers. This is in the rural population and also in the urban population. So overall, when you look at the family, I mean, female and male reception, we can see females, more than 62% of the female respondents said Rose can actually initiate a conversation about the use of contraceptive with her healthcare provider. Overall, a quarter of the respondents are not comfortable with the woman initiating conversation about with her provider about the contraceptive. We can see most of the male respondents, the last column, most of the men respondents, 37%, are more than a woman. You can see 17%, they said Rose should not initiate conversation with their healthcare provider. So when we compare the two, female and male, actually most of the male are not actually comfortable with that. And the same thing in the rural population, opposed to the urban. Next slide. Here we use also Likert scale. In overall total, the providers did agree that women can initiate. This is a conversation between the providers. This is a provider perspective. 90% of the providers agree that women can initiate conversation about using family planning with their healthcare providers. So meanwhile, 96% do agree that when discussing contraceptive with her healthcare providers, they actually pay attention. So the key message here, male respondents are not comfortable about women initiating conversation about contraceptive. That is showing in the slide there, 82% of the male respondents are not actually happy. Do the female respondents agree in all scenarios? Thank you. I think that's just a snapshot of the findings from the social norms assessment. As Chris mentioned, the link will be shared in the slides, and we can read more about the insights of the findings. Thank you.
Thanks, Martha. Yeah, as you mentioned, I saw a question in here about the slides. The slides in the recording of today's webinar will be available on the Momentum website, hopefully within the next couple of days once the files get shared and uploaded. Thanks again, Martha. I put another link to the full report because I know you were only able to cover just a smaller selection of the findings. I think there are a lot of other rich findings in that report for those of you that are interested. We're going to turn now to take a little bit or to hear a little bit about how the results, and the findings from this assessment have actually been used in terms of programming. And so we're going to turn it to Male Herbert, who is the Social and Behavior Change Advisor for Momentum Integrated Health Resilience in South Sudan, to talk about the use of the social norms assessments in the co-creation workshops for social and behavior change action plans at the county level, along with other program implementation. Male, over to you.
Thank you, Chris. I will be presenting the use of social norms assessment as a catalyst in shaping and adapting SPC packages and interventions in South Sudan. Using the findings of social norms assessment, MA was able to conduct SPC co-creation workshops at the county levels in order to produce county or context-specific action plans. So the workshops consisted of a wide number of stakeholders at all levels of the county, and this consisted of a number of key stakeholders, for example, the village chiefs, the health facility staff, the county health officers, the religious leaders, and etc. The objectives of the co-creation workshops were not limited to reviewing and socializing the stakeholders with the findings of the social norms assessment, and this created an avenue to get involved and generate consensus from the key stakeholders through participatory engagement in the development of county SPC action plans. And then following this, we're able to discuss how to use data for decision-making processes, basically the data from the health facilities pertaining reproductive health, family planning, GBV, etc., and as well as to monitor and evaluate SPC interventions in supported counties. Of course, this also provided a meaningful collaboration for breakthrough action and MA in adapting, pre-testing, co-designing the key SPC tools that are linked with the key behavioral determinants in the action plans. Next slide. Most importantly, the process consisted of a rapport establishment, because as you know, issues around the norms, issues around the reproductive health are very private, and most people do not like how they don't feel comfortable discussing about it, and we are able to establish a favorable environment for all the key stakeholders to discuss and at the same time to participate in developing interventions to address those norms. There were also value clarifications on gender, GBV, and the norms. They were shared with the key stakeholders. And then we were able to have presentations of the findings of social norms assessment that acted as a baseline to reflect on how life is taking everyone, or is being, how the norms are limiting number of people or the community members in accessing reproductive health, family planning, and menstrual hygiene management. And then, of course, there were an avenue given to share the tools and also the activities that momentum, the great health resilience, together with its key partner for SBC, that is breakthrough action, were already implementing or are already for designing or pre-testing. And these were not limited to the male engagement board game for family planning, the county or the community dialogues for gender and GBV, the partners for defining quality and the community action cycle approaches, and etc. Next slide. Looking at the tools that breakthrough action and momentum were able to develop following the utilization of the social norms assessment, included the community dialogue tool that has been proved to be very effective in strengthening interpersonal communications between communities. And these dialogues consisted of the generational dialogues, dialogues between communities and the providers, and the dialogues between parents and their adolescent girls and boys in ensuring effective use of healthcare services and health information for reproductive health, GBV, and so on. Throughout, DA and MA were able to review their findings, were able to review the recommendations, and also look through the SBC specific recommendations that informed the co-design and prototype of those tools that I just mentioned. Most importantly, MA was able to adopt local context. As we know, in South Sudan, we have multicultural communities, we have the pastoral communities, and we have the nomadics. So we're able to adopt a local context where we implement, monitor for adaptive management along the key stakeholders, and also using the local implementing partners to influence the specific groups. that are known as the reference groups in those communities. Most importantly is the Big 10 value proposition, where Breakthrough Action and MA together worked on to come up with a Big 10 value composition known as Build It Together or Hand in Hand in order to address the sensitivity of the communities around around family planning issues. Next slide. Looking through the Big 10 value composition, we were able to come up with what is known as Build It Together or Hand in Hand Big 10 value composition. And this was simply to address the concerns or the sensitivities around the term family planning, because family planning basically is perceived as limiting or making people not produce and so on. So the value composition was able to address the concerns around the family planning sensitivity in the communities, where we're able to unpack the meaning of family planning among the key audiences to determine what will be meaningful value composition, and at the same time that could be more acceptable and more user-friendly in the communities that we work in. And most importantly, our focus was on value composition that people can relate to instead or based on other SPC evidence campaigns, so that it becomes more friendly and people are able to remove the wrong misperceptions about family planning. Messages specifically emphasize the family benefits, the positive values and perceptions related to child spacing, and as well as child well-being in the communities. Next slide. The next steps following the co-creation workshops included the startup of small doable activities in each of the communities, the BOMAs and the PAYAMs where we do operate in, and where we're able to set up an environment for community dialogues with the key influencers and their community members, dialogues between the religious leaders and their congregations and so on. And all these were focusing on GPV, sexual reproductive health, menstrual hygiene management, and the behavior of the providers. Again, we are able to establish a supportive community groups in the communities where women groups were supporting first-time mothers to access safe motherhood services, family planning and other reproductive health services, and also working through various avenues to engage stakeholders to support family planning and reproductive health services. We're able to consolidate the county action plan and able to gain an approval from the county authorities in order to have a working tool for each county where resources can be used to implement those activities. Next slide. Using the findings of the social norm assessment, we realized as MA that there is need to deeply penetrate the communities. And as a result of that, we're able to onboard two community-based organizations to implement context-specific SBC packages in 2 counties. And the 2 CBOs were able to conduct cooperation workshops to come up with the county-specific issues and also prioritize their own problems, solutions, and all these were linked to MAS and Breakthrough Actions tools where possible. We're able to conduct organizational capacity assessment for the 2 local organizations, where we also come up with capacity development plan in order to enhance or in order to spearhead SBC interventions in those 2 counties. Most importantly is the technical assistance that we always do provide for the local organizations in order to keep pace with the changing environment and at the same time, being nimble and also being more resilient to the community perceptions of family planning and SBC. Next slide. The norms assessment enabled us to scale up SPC tools in a quite number of counties and also in quite a number of communities. For example, we're able to scale up partnership defined quality that was pre-tested in Magui County to 3 additional counties. And again, we're able to have a partnership defined quality specifically focusing on the youth in 2 additional counties where the communities together with the providers define, implement, monitor, and also evaluate quality improvement processes in the facilities and at the same time to the communities. I know this approach is very, very important, and it links community mobilization, resource mobilization together with the quality improvement, and it addresses issues around access, issues around quality, and issues around poor provider-client trust or communication. Again, we're able to adapt other SPC tools from Breakthrough Action, and this included the male engagement tool for family planning, the menstrual hygiene management board game, the safe motherhood tools for male engagement, and at the same time, the provider behavior change, the community action cycles, and the partners and defined quality. Next slide. Well, my next slide are the questions and answers and the discussions, and I want to thank everyone for listening. And if there are questions, I will be more than happy to answer.
Thank you, Male, for your presentation, and thanks to our other presenters. We do have plenty of time for Q&A today. We actually have about half an hour remaining in our session. I've seen several things coming in on the chat, so we'll get to those, and some of them were answered by other colleagues. I just want a couple of other housekeeping issues as we close up. I just put into the chat a link to an evaluation of today's session. If you can complete that during the Q&A or while after the session, we would really appreciate it. That will help us know how we did today, but also help us think about how to make sure our webinars and other events are really useful in the future moving forward. So again, the slides will get shared. I know that's been a big question. There were a lot of details in the slides that we didn't get to necessarily discuss. But also keep in mind, there is the longer report, which has been put into the link has been put in the chat once or twice, but I will put it again here so you can click to it if you want to right now. The last thing that I want to mention before we get to Q&A is to just put in a little plug for another Momentum integrated health resilience product that launched today. We've been working with USAID's Knowledge Success Project on a series of their podcasts called Inside the FP Story. And so this is a 4-episode radio program, essentially, that focuses on family planning and reproductive health in fragile settings. I've put a link to that in the chat. And the first episode was launched today, and there will be new episodes coming out for the next 3 Wednesdays. And one of them does include a lot of information and a lot of interviews and discussion around social and behavior change, gender norms, and that type of thing in fragile settings. So if you're interested in the topic that we've been covering today, the podcast might be something that you're interested in as well. So I definitely recommend that you check that out. So thanks for that little aside. Onto the Q&A. There were a couple questions that came in around the selection criteria for study participants. And so I'm thinking, Paul, you might be able to answer these. So one was just a general question on the selection criteria. And then the other is, just is there a rationale between around the selection process, or was it random? And then finally, are the findings available by county, by study setting or area, if there were differences? Paul?
Yeah, thank you very much. And my colleague Moses can complement, but this was a qualitative study. So right from the beginning, we used purposive sampling, so non-probability sampling techniques, but the emphasis was on making sure that the different social categories of people are represented. So not in representation in terms of statistical representation, but in terms of the different social categories, appreciating that women in rural and urban areas are heterogeneous, and we need to pay attention to the different social categories of younger people between 15 to 24, male and female, as well as adults 25 to.
Great, thanks, Paul. Another question came in around the, sorry, Paul, did you want to add more?
Yeah, he's trying to speak, Chris, but I believe his mic is a little muted. So hold on. Your connection is not very good. So wait for a second, wait for it, and then speak again.
From within those
again.
Because yeah, thank you.
Paul, I'm sorry.
I can do that.
Paul, we couldn't hear you because there was a problem with the connection. Could you start again? We got the initial part when you talked about having the different categories, social categories involved, the youngers and a little older, and then you cut off. Could you say it again?
Oh, okay, sure. So the main point is that we used non-probability sampling or purposive sampling. And what that means is that we were not going for statistical representation in terms of numbers, but at least what we did is to represent the different social categories of participants to make sure that there is representation along the lines of the different social categories, given that the counties we went to were heterogeneous. Some actually were predominantly pastoralist, whereas others were not pastoralist, and also representation of the different age groups within the reproductive health age. So basically our guiding principle was saturation, to make sure that we collect data until we feel that people begin to repeat themselves. From the perspective of qualitative sampling, it means that you have reached time to stop. You have been more representative enough when you start getting the same information from your respondents. Thank you.
Thanks, Paul. The next question is around the validation workshops that were mentioned a couple of times, I think both by Martha and Male. So if any of you who presented, if you could speak to the feedback you received from stakeholders during those validation workshops or the co-creation workshops, were there any findings that stood out to people, either positively or negatively?
I can take off, then Martha will complement. Yes, during the SPC cooperation workshops in the counties, the findings were validated by the stakeholders in the counties. And most importantly and surprising was that more norms emerged from the communities. So this therefore enabled us to understand that each of the counties or each of the communities actually have different norms and beliefs. And that is where the power of context-specific SPC co-creations resonates. The discussions together with the stakeholders also resulted into, they were able to reflect, they were able to pause, and they were able to think outside of the box. Assuming these norms were not there, how would life be? Assuming that these norms were addressed, how would life be? So they were able to reflect and come to a consensus that if these norms were not there, life would have been better for everyone, and everyone would have enjoyed life better than the way it is as of today. And this led to suggestions of long-acting action plans moving forward together with key stakeholders. Again, the discussions also led to more doable actions that were led and also owned by the community themselves. They were able to reflect, identify the issues, come up with the root cause analysis, and also come up with way forward to address those specific norms or changes or challenges that are posed by the norms. So yes, I can say that the norms were validated, and more other norms also emerged in each of the communities where the cooperation workshops took place. Martha, if I can add.
Thanks, yeah, go ahead.
Just to add, during the validation workshop at the national was done at the national level, and actually was represented from all the study locations. There are some partners, including the Ministry of Health, the USAID, implementing partners afterwards. And the findings were actually validated and was representative acceptable. And also, they have also added some recommendations to the some of the proposed activities that can help MAR to design their intervention, SPC intervention. I think you can go through the report and see further some of the recommendations mentioned there.
Yeah, Chris, I just wanted to take out one thing that is in the comments, but also that came up during the validation meeting, where some participants actually contested some of the norms, saying that although it is generally believed like that, the practice is different. And that was when it came to the issue of child spacing and postpartum abstinence. And we were told that although that is what is generally believed, but the practice is quite different in that even when it comes to postpartum abstinence, the women do abstain, but actually the men end up taking up either another wife or finding another sexual partner. So again, there are power relations around postpartum abstinence with women carrying the burden and the men sort of getting another partner. Thank you.
Thanks, Paul. Yeah, you beat me to it. That was going to be my next question for all of you. And so Male and Martha, maybe if you have any thoughts as well. The question was, did the study distinguish between norms and actual practices? So there may be examples where the norm, as Paul mentioned one specifically, were there other norms or where norms and practices differed?
I can, from my experience through the SPC cooperation workshops, yes, the communities themselves, they do distinguish between norms and practices. As the populations are changing, there are yet those reserved communities who still are so preservative on the norms and they also practice it. Meanwhile, the younger ones and also as they adopt newer behaviors, there are already others who perceive these norms to be, in quotes, and what they practice is actually different from what the norms dictate upon them by the communities. So that's one thing that I noted during the cooperation works of the Condis and also during the community dialogues. Thank you.
Go ahead, Chris.
Thanks, Male. Another question that came in, a comment and a question. So it might also be difficult to promote family planning in such settings that you've described today. Did informants note any actions toward healthcare providers who provide information about family planning and provide, information and services for family planning?
Yeah, I could respond to that, and my colleagues could add. One of the things that came up, and Melinda made reference to it, is that some of the providers actually would be negatively sanctioned if they provided information or even modern contraception services to women who need them, especially without consent of the husband or without consent of the family, because when South Sudan is, especially in the rural areas, is a collectivistic setting where even the husband is not, does not stand as an individual, but is part of a community, is part of an extended family. And so sometimes providers were threatened by a mob of an extended family or a clan if they provided contraceptive services. Also, a woman is married into a clan, not to a husband. So the thinking around the individual is quite different in some of the communities we visited, including the pastoral communities, where somebody is married into an extended family, a clan, and dowry is contributed, and the decisions are not taken by individuals, but by the collective. Thank you.
Thanks, Paul. Next up for Male, what were some of the biggest takeaways or lessons for you during the process of taking research findings and turning them into actual implementable activities?
Thank you, Chris. One of the most biggest takeaway I can say is the power of the communities in influencing norms and finding solutions to the desired changes. These community leaders are very respected, and they have the power to influence either negatively or positively. And those who are under them goes by whatever they decide. So that's one of the most important takeaways. And this comes up with the importance of the population workshops together with the community leaders who influence the norms, who practice the norms, and who are ready to change these norms to a desired environment for everyone. Number two, to sustain a change in the communities, there is always need to target all the players along the behavioral ecosystem, because the youth are almost changing. They learn about the norms, but in practice, they do not, most of them do not practice. Half of them practice, and then others do not practice. It now depends on if they're urban or the rural settlements. So now having each of the target groups along the behavioral ecosystem is very important so that messages can be diverted, messages can be directed towards the specific target groups along the behavioral ecosystem. The next takeaway that I was able to give out, I'm able to give out is that the local solutions are always cheaper. They are sustainable and they attract local solutions. Because when we did the co-creation workshops, the issues came up from the communities, and the same communities were able to mobilize resources to address those issues. And this builds sustainability for these programs. Because if the programs are designed at a higher level, the communities become passive recipients. They will need everything to be done for them, thinking that everything is being addressed by the donor funds. The fact that we engage them in creating local solutions, it becomes more sustainable and local owned by the communities. The last thing I want to say here is that communities can change and communities are ready for change. What we only need to do is using the right tools and the right approaches. Because if you look at the trends of changes or the trends of acceptance of family plan and reproductive health services, you can't believe it 5 years ago or 10 years ago that today, communities are able to come up openly disclosing their use of family planning and RHH services. So the communities can change. We need the right tools, right approaches, and get them on top of these approaches. Let them lead, let them implement, and provide support where necessary. Thank you.
Thanks, Mala. We've got one or two more questions, but again, for those of you, please feel free to drop another question in the chat. We do have a few more minutes for it. So here's a question that just came in. You mentioned earlier the example from Yambio in which the woman and the health provider could be punished by labor at the chief's home. Do you know how this practice, the punishment by the chief, would have been seen in the wider community? Would they have been supportive or condemned such a practice?
Oh, that is actually interesting because it depends on the depths and the breadth with which the norms are held in the community. If the chief is a loner who is stuck in the past, that is one thing. But if these norms are shared by the community, then the community would actually, the chief would be heralded for doing the right thing to punish the woman and the provider. But these norms, as Herbert mentioned, these norms keep changing because the norms are dynamic. And if it is in an area where there has been norm shifting, like an urban area, or people have gone to school, or for some reason change has happened, the perspective would be different. But from the perspective, from the insights from where this chief was speaking, the community tended to be supportive of this kind of social sanction against the providers and the woman who was seeking modern contraception without consent of the husband and the larger family. Thank you.
Thanks, Paul. Male and Martha, do you want to add anything onto that?
No, I think he did it all. Thank you.
Okay. Thank you. I think we've covered all of the questions that have been asked. And most of them we've done here. There were a couple smaller questions, quicker questions that I think were answered in the chat. Again, if you do have a question, we can wait a minute while we wrap up to address that if you want to get that into the chat right now. But otherwise, I want to thank our presenters today, along with the entire team that worked on this social norms assessment. I think, as all of you know, it really takes a real team effort to carry out something like this, from conceptualizing it all the way through where we are today in terms of dissemination. So thanks to the entire group from MIHR that's had a role in this. And so I've put into the link, into the chat, the link for an evaluation. If you're able to complete that, we'd really appreciate it. And it looks like we did get one more question in while I was wrapping up here. So I'll ask that since we do have some time. One of the norms found was that fathers decide when their daughters should get married, and this was linked to economics and financial gain from the bride price. What was the community's solution related to this?
I guess this might go to the SBCC team, but what I know from experience, because these kind of norms are quite common in East Africa, is that this is when it gets to issues of individual agency, but also collective agency. So if, for example, individual agency, then it would mean that the girl in question would start to negotiate, or the girl could team up with the mother and they negotiate, or the girl could team up with the siblings and they start to negotiate and challenge this norm. So in terms, but sometimes the mother is part of a VSLA, a Village Savings and Loans Association, and then within that group, they can begin to discuss and start to challenge these norms. But this really depends on the context, because there is really a stronger norm that the father has the final decision. Thank you.
Thanks, Paul.
In addition to what Paul mentioned, yes, those norms are evident, and the solutions vary per community. You know, in pastoral communities, it is still very, very strong. And what we have been doing as a momentum is to engage the parents in discussions and in dialogues about MNCH. You know, all around this comes around the ages of MNCH, where when a girl reaches MNCH and communities perceive that she's actually ready to become a woman. So what we have been doing here is that we have been engaging communities in dialoguing and to change the activities of ceremoning girls at the point of MNCH for marriage, or like showcasing this girl around the point of MNCH for purposes of marriage, to discussing other benefits of abstaining, benefits of later marriages, and benefits of allowing this girl to grow until she's 18 years and above before she is showcased to the communities for marriages. So the dialogues have been very, very important. And of course, we have been engaging the community leaders. Whenever we have any community-based activities, we do not miss out issues around early marriages and forced marriages. So we have mainstreamed issues around JBV, early marriages into every and each element of our programming in the community, so that communities understand that MNCH is not an approval for a womanhood, is not an approval to showcase this woman for men to come and marry her off. So the dialogues have been very, very important. And of course, also the element of the education. Now, in some locations where education avenues have opened, some few girls who have gone to schools were able to delay those marriages, and parents have been sensitized to support their girls at least to go to school, so that they do not resort, or they do not push these girls for early marriages for economic benefits or for other social benefits. Of course, the element of the menstrual hygiene management. We have been engaging the parents in menstrual hygiene management on how to support the girls around menstruation. So during the discussions of the menstrual hygiene management board game, we debunked the myth and misconceptions on the heads of the parents that MNCH is equal to maturity for marriage. So we are discussing quite a number of issues, the consequences that this girl is likely to get when she is married at an early age of 13 or 14 years old. So the menstrual hygiene management board game has also helped a lot in reducing the community acceptance of early marriages around MNCH. Thank you.
Thanks, Male and Paul, for responses on that. I think we have two more questions. One, I think, is a quick one, so we can do that first. It says, I see the data is disaggregated by urban and rural, but did you look at agricultural versus pastoral?
Moses, can you address that? I know you did in the chat.
You can say it verbally, and we can translate to French.
Yeah, thank you for that. We did not disaggregate data according to occupation of the respondents, simply because we did not ask them whether they were pastoralists or whether they were, or maybe they were actually engaged in agriculture as a source of livelihood.
Great, thanks, Moses. Okay, I think this will be our last question that we have a chance to get to. And I think this is mostly for Male, and you've answered it a bit, but you can maybe go into a bit more detail and offer another example or two. But how did the results allow you to improve your activities, and what were the action points you took to achieve behavior change in the community?
From the point of the implementation, the results were very, very important, and they were able to improve our activities in a number of ways. Number one, we're able to understand our audience, and we're able to understand the barriers in accessing family planning and reproductive health services with the providers, including the gaps between the provider and client communications. So what we're able to do is as an action point was to conduct a deep dive into the real issues into each of the communities through a co-creation workshops. So now, once the co-creation workshops were done, the communities were able to identify more other norms. For example, in one of the communities, we had issues around the monkey meat in courts, and the story is long and I cannot explain it. And the monkey meat has been one of the norms in the communities in order to allow girls and women to deliver without the presence of healthcare providers, because they never trusted the providers. So again, as I said before, these norms are different in each of the communities. And in some of the communities, they do not allow the birthing positions. They do not allow men to be present in the facilities, and there are quite a number of norms. So the co-creation workshops were able to unpack more of the norms and more of the barriers that prevent women and boys from accessing family planning and RHS services. Most important are the cross-generational dialogues. When we engage the parents and the younger generations in dialogues, this created a generational change. The parents were able to, the adolescents were able to understand reproductive health and family planning issues. Meanwhile, the older generation, especially the parents and key stakeholders, were providing conducive environment for the adolescents and the younger generations to access and also use family planning services. Most importantly is on the environment, there was an open disclosure among the beneficiaries to use family plan and RHS services, which wasn't the case before. Actually, one of the community members said that for the last 3 years, she never ever wanted anyone to know that she was using family planning services, because it would be dragged before the local court. So through the dialogues that we adopted, through the partnership defined quality approaches, and through the community action cycle, communities became, family planning use became a normal thing. They're able to understand that using a family planning is not a thing. It's not a social misfit, and people were able to openly come up and give out testimonies that I am using, and it has never caused for me the abnormalities that other people do talk about. It does not cause infertility and many other myths and misconceptions. And that's how this really helped us improve our programs. Of course, as I did mention, the big tent or the big umbrella brand, where we were able to develop messages, radio spots, and the print media in the communities where people are able to listen, others can read, pictorials, and so on for enhanced messages and communications about family planning. The provider behavior change is very important. Of course, we realize that providers are part of the communities, and they are also influenced by these norms. So through the provider behavior diagnostics and implementation tool, we're able to engage providers in identifying the factors that prevent them from providing services, the influencing factors at the level of the providers, at the level of the health system, at the action plan to improve client-provider interactions and also to reduce bias and discrimination for providers, irrespective of their marital status, socioeconomic status, cultural background, etc. Thank you.
Thanks, Male. I think we'll have to wrap here. We only have about 1 minute left. So once again, thanks, Male, Martha, Paul, for your presentations today, and to all of you in the audience, thanks for attending. And I also want to make sure that we thank our interpretation team that's been working behind the scenes to make sure that this was available for our Francophone colleagues. So thanks to all of them for their support on this. If you have a moment, I've put some links into the chat. You might have to scroll up a bit, but you can find a way to sign up for the Momentum newsletter to keep up to date on this and other things coming out of Momentum. Also, there's an evaluation that should take you, I think it's fewer than 5 questions. It should just take you a couple of minutes. We'd really appreciate you taking a couple minutes to fill that out for us, as well as you can find the full report from this social norms assessment on the Momentum website. So thanks once again, everyone. We hope you enjoy the rest of your day.